So again, thank you so much for having me, and thank you, Dr. Ross, for such an important and passionate topic. I really appreciated your presentation. So today I'm going to be talking about my research project, Barriers to Healthcare Experienced by Pediatric Rheumatology Patients. I have no relevant disclosures or conflicts of interest. This project is supported by the Arthritis Foundation, for which I'm very thankful, and very thankful to also be an AF funded fellow. Without the Arthritis Foundation, I wouldn't be able to be doing what I'm doing now, which is what I love. So our objectives today, I am just going to briefly talk about some background of health disparities in pediatric rheumatic disease, very briefly, especially given the topic of the summit today. And then we'll be talking about my research with some aims or methods, some very preliminary results that we have, and discuss some limitations and conclusions. So again, a very brief background. Some definitions as we get started, just to review. According to the Healthy People 2030, a health disparity is a social determinant of health, or a health disparity is a health difference that is closely linked with social, economic, and or environmental disadvantage. And then social determinants of health are the conditions in the environment where people are born, live, work, play, and worship, and age that affect a wide range of health, functioning, and quality of life. And so what does this mean for our research? I think that we should really be using these concepts to be guiding principles in our research, which can help aid in our transitioning from a concept of race as a risk factor for disease towards one that's recognizing that racism is a risk factor for disease. So what do we know about health disparity in pediatric rheumatic diseases? So health disparities in pediatric rheumatic disease manifest in many ways, just as it does in all diseases, by race, ethnicity, socioeconomic status, and geographic location. Differences in disease prevalence, disease outcomes such as severity, morbidity, and mortality, healthcare access, insurance status, therapeutic options, quality of life, mental health, and inclusion in research can all be found, as well likely as differences that I did not list here. So our research is recruiting patients largely with JIA and lupus, so I'll briefly go over some examples of disparities that are seen in these diseases. So as far as disparities in JIA go, a care registry analysis found that in JIA, the racial demographics are 93% white, 5% African American, and 3% Asian. Though I will say that this is very limited given it's recruited of patients from care registry sites and has language gaps as well. African American children with polyarticular JIA were found to be more likely to have joint damage on imaging, and African American, Asian, and Hispanic children represented higher proportions of RF positivity. African American children with polyarticular JIA have been found to have higher disease activity at first visit, as well as over time. And children with Medicaid status have been found to have a lower health-related quality of life and higher disability compared to those who are privately insured. In childhood onset lupus, disparities are also very prevalent. You can see differences in disease prevalence, as well as the prevalence of lupus nephritis by race and ethnicity. There are disparities in renal transplantation. The 5-year rate of renal transplantation among African American children has been found to be about half that of white children. Comparing Hispanic to non-Hispanic children, there's about a 30% lower rate of renal transplantation and a 30% lower rate of transplant amongst children who are on Medicaid as compared to private insurance. There are disparities in the lupus nephritis associated end-stage renal disease mortality as well, with African American children having an almost double increased risk of death compared to white children. This is a graph from a study of children with Medicaid showing the prevalence rate ratio of lupus and lupus nephritis by race and ethnicity, as well as by gender. And as you can see, the prevalence of rate is increased amongst all non-white demographics. So what are some of the gaps in the current literature? I think pediatric specific data is limited, and most of our existing data on health disparity is based on race and ethnicity as opposed to the true drivers of these differences. Lastly, there is a gap that exists in the representation of diverse populations in our studies and trials. So now I'd like to shift my focus to talk about my own research, which is barriers to healthcare experienced by pediatric rheumatology patients. Our research question for this project is, what is the prevalence and disparity of barriers to care experienced by pediatric patients with rheumatic disease? And can these barriers be associated with disease activity, quality of life, or satisfaction with the healthcare system? Our hypothesis was that any experience of a barrier would likely be very prevalent, but there's going to likely be an increased experience of barriers amongst patients who are of historically disadvantaged backgrounds, those with higher disease activity, those who are experiencing poor health-related quality of life, and those who are experiencing a poor satisfaction with the healthcare system. Our aims for this project were as follows. Our first aim was to just identify the barriers to care. And our second aim was to examine the relationship between disease activity, health-related quality of life, and satisfaction with the healthcare system to experience of barriers to care. And then our third aim was to compare the pediatric rheumatology provider's perspective on the impact of structural barriers on patient care. For our methods, we are recruiting patients and caregivers of patients with lupus, polyarticular JIA, and systemic JIA. We chose these diseases as diseases that are very frequently seen in our clinic and ones that represent high medication and appointment burden. This is a mixed method study, meaning that we're doing a qualitative portion where we are undergoing focus group interviews and as well as surveys on experiences of barriers to care. And then for a quantitative portion, we will have a barrier survey listing some specific barriers that are identified in our interviews, as well as looking at disease activity, some measurements of socioeconomic status, some health-related quality of life measures, as well as healthcare satisfaction measures. So for our first aim, we are doing qualitative interviews. We did a propulsive sampling, hoping to recruit patients that would be more reflective of the disease demographics. We did focus groups of patients separately from focus groups of parents, and we conducted interviews in both English and Spanish. Our second step of our first aim is to use a survey that's going to be informed by the interviews that we conducted regarding barriers to care, and we'll distribute this to a much wider group of patients. We also hope that surveys will help reach some patients who might be reluctant to participate in an interview format. And then we'll also be gathering some demographics and socioeconomic status measures. For our second aim, we're looking at the relationship of barriers to care to patient outcomes. So we'll be looking at disease activity. Via chart review, we'll obtain a SLEDAI score as well as a JDAS score for their respective diseases, as well as age of disease onset and their disease duration. We'll also be obtaining health-related quality of life and healthcare satisfaction surveys. For our third aim, we're hoping to obtain the pediatric rheumatology provider perspectives on barriers to care. So we'll be doing this through a survey distribution through CARA. This will help us assess the provider perspectives on the frequency of specific barriers. There have been similar studies in adults with lupus that have found that providers aren't necessarily good at identifying barriers in their patients. So we do have some very preliminary results from our interviews. Our interview participants are as follows. We had 19 patients and 16 parents. From a disease perspective, 12 of these patients had lupus and 7 had polyarticular JIA. Our sex distribution was 16 female and 3 male. And then our race and ethnicity is as follows. We had 7 Hispanic patients, 6 patients who were white, 3 patients who are African American, 1 Asian patient, 1 patient who is American Indian, and 1 patient who preferred not to answer. We did experience some recruitment challenges. So I think that one of our biggest limitations is that those who are experiencing the most barriers to care may also be those who have the most barriers to research participation. So we did have some difficulty contacting patients. We had issues with patients feeling like their experiences might be very uncomfortable to discuss. Parents and patients brought up concerns about participating in an interview, that they might be spending time away from work or school. And some people, when declining, said that they had, lack of trust in research process. And then we did have pretty high no-show rate. So 7 patients who had been scheduled and no-showed to interviews, and we had to have pretty frequent rescheduling as well. Here are some of the common concerns that came up during our interviews. Patients and their parents were often concerned of cost of medications, health insurance coverage when children age out of their parents' insurance, the travel distance to see a pediatric rheumatologist, perceived comfort in caring for rheumatic disease from other healthcare providers, particularly getting emergency care. Patients were often concerned about school attendance. One of the things that they had been asking for was more support groups for children and families to meet other people who are going through similar issues as them. And then some patients and parents brought up issues of disease stigma. Some limitations in our study that I would like to point out. Our study is a single center, so we do lack diversity in our participant demographics, as well as a very geographic limited study. We were limited to English and Spanish speaking patients only. We did have, like I said, some recruitment challenges and some concern that there might be some possible hesitancy towards disclosure of barriers to care or even negative experiences in the healthcare system in an interview setting. And then from a physician perspective standpoint, we do see, or I do expect that most of our responses will come from larger tertiary academic centers since we are distributing the provider survey through CARA. So for some conclusions and future directions, pediatric rheumatic disease has been shown to have significant healthcare disparities. There's a gap in what the specific drivers of these health inequities are. Barriers to care is one way that social determinants of health manifest, which is why we chose to do this as a target of our research. And we hope to identify specific barriers to care and investigate its role in disease outcomes to hopefully identify potential for expansion to multiple centers, a development of potentially a risk screening tool, and the identification of targets for intervention. I want to end with some quotations from some of our participants. Given that this is qualitative study, I do think that some of these are particularly moving. So one patient told me that I personally got made fun of growing up, my knuckles being 3 times the size of everyone else's. So I tried to hide it from people, but now I feel more comfortable talking about it. There's no need to be ashamed of it because it's out of my control. These are some quotations from some young adults and older adolescent patients. You either pay a bunch of money just to get the help you need, or you just continue on and still be in pain. When I turned 18, I had to find new insurance, but I had to pay full price of my meds, but I can't go without it. So it's hard dealing with insurance, paperwork, and being in school. Is it worth paying for this? Should I just not pay for it, and will I be fine? And then lastly, my mental health gets really bad, but I can't just go see a therapist because that costs money and I don't have a job to pay for it. Some quotations from our parents. Nobody seems to understand her situation, the chronicity, just her basic human needs. They, meaning the school, just weren't there for her. They made her feel less than adequate. We've been met with almost like we have a plague. And then another parent said, one of the biggest things I'm concerned about is when my daughter turns 26, how is this medication going to get paid for? And then I have to get prescriptions for multiple kids. I go to do her taxes and I'm looking at receipts and I'm like, I've worked for nothing. My husband, he's working just to make sure that we have health insurance. I feel like I'm a single parent. And I think, do I want to add that stress and tell him we got a letter, the insurance is no longer covering these meds? One parent brought up some concerns during COVID. She said when COVID came up and everything shut down, suddenly I couldn't have all of my kids with me at the doctor's office, and that made things really difficult. And then one parent said after her last COVID scare, she did not go back to work because she's an essential worker and was afraid of her daughter getting COVID. And with that, I would like to give some acknowledgments. So Dr. Martha Rodriguez is my primary mentor on this project. I have a wonderful scholarship oversight committee consisting of Dr. Alvaro Torrey, Dr. Stacy Tarvin, Dr. Melissa Oliver, and Dr. Brandy Stevens. Dr. Kiana Johnson is a consultant on my project, and she's been absolutely essential to this work. I'd like to thank the CARA Health Equity Research Work Group for all of their feedback and help, especially Dr. Jen Wu. Obviously, I'd like to thank the Arthritis Foundation for allowing me to complete this work. And then lastly, our patients and caregivers who are so generous with their time and their vulnerability during these interviews. Here are some of my references, and I would be happy to take any questions.